Thank you all for coming to the second talk of the term. Our speaker today is Faith Matcham, who did her undergrad at Sussex, actually, in psychology. Yes, good. And then her master's, PhD, and postdoctoral appointment at King's College London. And then Faith came back here as a lecturer and just a couple of days ago, presumably, became a senior lecturer in psychology. And today we will be learning a lot about depressive disorders. So thank you very much.
Great.
And
Lovely. Thank you so much for the introduction and for the invitation to speak today. So by way of background, I'm a health psychologist, which means I specialize in the relationship between mental and physical health. And as a researcher, I'm specifically interested in how we can use digital technologies, specifically wearable devices and smartphone sensors, to improve how we can measure and manage symptoms of long-term illness. Today, I'm going to be talking about a very specific piece of work that I was part of during my time at King's, which involved long-term digital data collection in people living with major depressive disorder. So I'm going to give a brief introduction to major depression for those of you who are unfamiliar with it. I'm going to give a very brief summary of digital sensing and remote measurement technologies, what they mean and what they are. I'm going to focus most of my presentation today on one study called RADAR MDD, Remote Assessment of Disease and Relapse in Major Depressive Disorder. And I'm going to use the data that we collected from this study to talk about the feasibility, acceptability, and usability of long-term digital data collection. And then I'm going to talk about some of our latest findings, looking at how we can use this data to predict really important outcomes such as depression severity and relapse in this population. So major depressive disorder is a severe form of depression. Depression actually encompasses around 5 different individual diagnoses, and major depression is considered one of the more severe types of depression. It's extremely prevalent. It affects around 30 to 40% of people at some point in their lifetime. And recent estimates say that COVID has contributed to an additional 53 million cases worldwide. So it continues to increase in prevalence with more and more people learning to live with this condition. It's really severe. It's characterized by a range of different symptoms. The 2 core symptoms are low mood and a loss of interest in daily activities, but it can affect a range of other aspects of life. It can affect our sleep, physical activity levels, feelings of self-worth, guilt. It affects our cognitive capacity, so our ability to pay attention and to concentrate and prioritize tasks. And in its most severe form can also bring with it feelings of suicidal ideation, so thoughts of self-harm and suicide. It is the world's second leading cause of years lived with disability. It counts for 14% of the world's years lived with disability. And it's extremely impactful. It's associated with increased risk of job loss, reduced quality of life, premature mortality due to a range of causes. It's associated with cardiovascular disease, increased risk of a range of different health outcomes. And it costs around 30.8 million euros to treat and manage effectively. And that was an estimate from 2017. So recent health economic updates will be even larger than that, given the COVID contribution. It used to be seen as a once-off or once every now and again kind of condition, but it's increasingly being viewed as a chronic illness that people continue to live with fluctuating levels of severity throughout their lifespan. And around 50% of the population with major depressive disorder will have what's called a relapsing and remitting cycle of disease. So they'll have symptoms which sort of peak and trough throughout their lifetime. Sometimes when the peak's high, that's what we call a relapse, and then they might go into periods of remission where they're actually living relatively symptom-free for long periods of time. And then something may happen which can accumulate in symptoms and lead to another relapse event. The way in which we measure depression typically is very limited. We are dependent on subjective self-report. So the gold standard measurement of symptom reporting in depression is almost exclusively subjective, asking people how they feel and how they have been feeling via questionnaires, rating scales, clinical interviews. If anyone's ever been through one of these assessments, it basically involves sitting down with a health professional or a screen and saying, how have you been feeling for the last 3 months? And then having to summarize a whole breadth of experiences in one tick box or in one answer. So very subjective. Based on retrospective recall. So we know that depression affects our ability to make decisions, recall things. We have no information about what's really been going on during the period of time that people are often asked to refer to when explaining their symptoms and their experiences. If you ask me how well I've been sleeping, my answer is much more likely to reflect how I slept last night than how I slept 2 weeks ago. It's also, measurement in major depressive disorder is really sporadic. It's dependent basically on when someone attends an appointment or experiences a flare in symptoms that they no longer consider to be manageable by themselves. So at a healthcare appointment, at a referral to an intake, so in response to a symptom flare or according to some arbitrary time point that has been set for them in terms of a research protocol or a care management plan. So not reflecting their natural trajectory and peaks and troughs of symptoms. So we lose a lot of information, and what we need to work towards are methods of data collection which incorporate more objective measurements that rely. I'm a psychologist. I love asking people how they feel. I would never suggest replacing that. I'm talking about adding to it with more objective information about how people have been feeling that's provided in real time so we can fill those gaps in knowledge. We know what's been going on in the 2 weeks since we last saw someone or in the last 3 months since they filled in this questionnaire. And that's continuous, that provides ongoing information over time to give us more powerful indicators of what's going on in people's lives. So digital sensing and remote measurement technologies are a really exciting opportunity to do this. And what I mean by digital sensing and remote measurement in this context is data that we can collect via your standard smartphone and wearable devices. So smartphones have a range of inbuilt sensors such as Bluetooth, screen usage, geolocation. You can track people's movements on a keyboard. You can sometimes get SMS and call log registers. So we can collect a lot of unobtrusively useful information from people's smartphone sensors. And you can also combine this with app-delivered questionnaires at a higher frequency than what you typically see in a standard research protocol. So a little app-based assessment says, how are you feeling today? And small rating scales for higher frequency self-reported symptoms. Wearable devices depend on what they can give you, depending on the price point. Some can tell you respiratory rates and galvanic skin responses and sweat and all sorts. But at the very minimum, you can get indicators of daily patterns of sleep and daily patterns of physical activity via heart rate monitors and a range of other inbuilt sensors. So by using these kinds of technologies, what we hope we can move towards is a method of measuring and managing depression which doesn't rely on knowing what's happening to people at these points when they are relapsing, when they're at their most severe, when they've had a crisis point, but actually incorporating continuous measurement to understand what's happening at these points just before they reach a point of relapse or a point of crisis, so that we can deliver preventative interventions rather than sort of reactive interventions in response to a major crisis. So moving on to the specific study that I'm going to be talking about today, this is called Remote Assessment of Disease and Relapse in Major Depressive Disorder, or RADAR MDD. It was funded by the Innovative Medicines Initiative. It was a private-public partnership between public sector institutions, hospitals and universities, and 5 different pharmaceutical companies who were all involved. It included 24 countries from across Europe and the United States, and it was a 6-year-long project. Radar CNS as a whole was looking at a range of different long-term conditions. My role specifically was to run the major depressive disorder work package. So the aims of our Radar MDD study were twofold. The first was to determine whether people would actually use the technologies for long periods of time, whether they would find it usable and acceptable to sort of interact with these on a day-to-day basis and integrate them into their daily routines. The second aim was to determine whether the information collected via these technologies was actually informative clinically, whether it could tell us things we didn't know about someone's clinical state, or provide information that was potentially predictive of future outcomes. So we had a multi-centre study design. We had 3 recruitment sites, one in London, one in Amsterdam, and one in Barcelona. We recruited participants from a range of different sources, from clinics, so active patients. We recruited people from existing databases and cohorts of people who were known to the hospitals as living with major depressive disorder. We did some online recruitment, so very varied. And we chose to do a cohort study. So this was observational. We weren't interested in intervening. We didn't want to change anyone's behavior or manipulate anyone into being in a particular group. We were purely interested in watching them kind of creepily for a couple of years while they went about their daily lives. And it was longitudinal. So we followed people up for as long as we could, basically until we ran out of money and time to do so. In order to participate, people had to have major depressive disorder and be considered at risk of a relapse within the time frame we had available. So they needed to have had at least 2 lifetime episodes of major depressive disorder, and the most recent one needed to be within the last 2 years. We were quite inclusive when it came to sort of other illnesses that people might be living with, whether it be physical or psychological. And we had to rule out some psychiatric comorbidities, so we had to exclude people with psychosis or schizoaffective disorder or bipolar disorder, because we wanted to be sure that we were actually detecting a relapse and not some other acute psychiatric event. We also excluded people if they were going to be hospitalized for long periods of time. So if they were receiving dialysis potentially, or if they were planning on receiving sort of hospitalized chemotherapy, anything that would stop them sort of going about their daily life as usual. Otherwise, we were fairly inclusive. And they also need to be willing to use Android for the duration of the study, which was something we will talk about later, but was quite an important part of this study. So at the back of this study, the sort of fundamentals of it were a very standard cohort study with very clear time points. They did a very detailed baseline assessment, which included basic sociodemographics, technological literacy, a history of their health, including their family history of depression, personal history of depression, and then measurements for depression, anxiety, physical functional impairment, illness perceptions, medication adherence, alcohol use, and service use. And then every 3 months, they completed a very similar variation of this. So every 3 months, we were collecting sort of routinely collected outcome data, this typical and similar to what they would either be asked to complete in a clinic or in a sort of standard research protocol. And so we had a 3-monthly schedule, and this basically continued. The arrow can continue there indefinitely for however long was available. So the people enrolled right at the beginning of our enrollment period could have participated for up to 3 years. The people who enrolled right at the end of our recruitment period could have participated for 1 year. So that was the sort of minimum and maximum amount of time that people could have potentially provided data for. So against the backdrop of this fairly standard cohort study, we implemented continuous measurement in 3 different sorts of areas. We asked people to download a purpose-built app, which they didn't need to ever interact with again. It just sat on their phone, collecting information from their sensors, anonymizing it, and then sending it to our servers and our data management platform. And they never needed to do anything with it. They were asked to wear a Fitbit for the duration of follow-up so that we could collect information about sleep and physical activity levels. And we also created a custom-built questionnaire app which delivered regular sort of self-assessments for mood, self-esteem, cognitive function, and speech. So they interacted with that on a regular basis as well. So going back to our initial aim to determine how usable and feasible this whole system was, we were interested in these 3 domains: feasibility, usability, and acceptability. To determine feasibility, we were really interested in paying attention to our recruitment rates, so how well we were able to get people into the study. We were interested in retention, so once they were in the study, how long they stayed in the study for, and their data availability. So once they were in the study, how much information were they able to provide? How much data could we collect? If anyone is interested in reading more on this, we have a paper published In BMC Psychiatry, I'm going to run through a whistle-stop tour of some of our key findings. So with regards to recruitment, across all 3 sites, we spoke to around 2,000 people in total, and of these, around 50% were interested in participating and 50% were not at all interested. Some of them thought it was just too much commitment, some of them just not interested in technology. Out of the 1,000 or so who did want to participate, about 30% did not meet our eligibility criteria, so couldn't continue in the study, and 70% were interested, were eligible, and pretty much all of them ended up being enrolled. A few didn't because of not attending their appointments or because we couldn't figure out how the technology worked in the early days and we made loads of mistakes. That only happened for 2 people, and then we learnt our lessons. So we ended up with 623 people enrolled, which is around 90% of the people who were eligible, and a much smaller proportion of those who we contacted in total. Just to describe our sample slightly, we had 623 total participants. The average age was around 46, and we had around 76% female, which is fairly typical and comparable to people seeking services in all 3 of the countries that we were recruiting from. Depression scores were fairly high, so over half the population were moderately severe or extremely severely depressed, and 20% were reporting active suicidal ideation at the point of enrollment. So overall, a fairly unwell group of people. In terms of retention, so the extent to which we were able to keep people in the study once they enrolled, we had 70% of people who completed all of the data collection at 1-year follow-up, and 80% who completed the study for as long as was possibly available for them. 20% asked to be withdrawn early from the study, and the most common reason for this was that they were lost to follow-up, so they just sort of disappeared and we couldn't ever make contact with them again. So if we can't get any outcome data from them, they were removed from the study. The second most common reason for dropping out was that they decided to switch over from Apple to Android for the purposes of the study, and they decided that the switch was just too difficult and they wanted to get their Apple phone back, so made that decision. Only 8 people said that the study was too demanding, and other reasons for dropout included relocation, divorce, all kinds of things that came up. The median amount of follow-up was 541 days, so around 18 months of follow-up in total. In terms of data availability, we summarised data from our 3 sources of information to get a feel for how much data was being provided by these participants. And so to talk these through one at a time, the first assessment we looked at was our app-delivered assessment. So participants had to do a mood questionnaire every 2 weeks via the app. They had to do an assessment of their cognitive function every 6 weeks, and they had to do a speech assessment every 2 weeks, where they were asked to record their voices into the microphone, and then the recording was sent off to our system. And actually, data availability for these, even though they were delivered all via the same app and typically all at the same time, data availability really, really varied. So for our mood questionnaires, our every 2-week mood assessment, around 30 to 40% of participants completed over 3/4 of the questionnaires that we sent them, which we think is a pretty good response rate. In comparison to that, around 40 to 50% only completed less than 1/4 of the cognitive assessments that were sent to them, and over 60% only completed 1/4 of the speech tasks that were sent to them. So there was a real discrepancy in how well people responded to these methods of data collection. And if anyone's really interested in delving into this, I'm very happy to talk about it in more detail afterwards, because I know why I think these things differed, even though they're all done by the same app. So very, very differing information and willingness to complete these different assessments. In terms of Fitbit wear time, people wore the Fitbit across the full amount of time for around 63% of the time. The average wear time was 15 hours per day and for 42 weeks. There aren't any, or at the time of this study happening, there weren't really any benchmarks for what we could expect in terms of Fitbit wear time for this scale of data collection. But we think getting 600 people to wear a Fitbit over long periods of time for around 60% of the time is pretty good going. And 15 hours a day of data collection is quite good. I don't think the smartphone sensor data is that interesting, if I'm honest, because it doesn't really tell us anything about people's thoughts or feelings or behaviors. What it tells us more about is potential problems with the technical pipeline, getting the data from the sensor to our platform, or potential errors with the sensors on the phone anyway. But just for symmetry, and not to look like I've missed out important information, our highest level of data came from battery sensors, and ambient noise sensors were the ones that provided the least amount of information. I don't think that's super interesting, but again, I'm happy to discuss it with anyone who would like to. So in relation to our sort of questions of are large-scale digital data collection methods feasible, participation rates, I am uncertain. We recruited 50% of the people we spoke to were not interested at all. But the people who were interested were really into it, and they were a really motivated, enthusiastic, and committed group of participants who stayed in the study and provided really good longitudinal data, leading to really good retention rates. So I would say that for those who were interested, it was fabulous. For those who were not, they were not interested at all. And in terms of data availability, I think the results are also variable depending on where the data was coming from, the requirements that participants had to fulfill to provide that data. So a little bit up in the air, a bit 50-50. So our next aim was to look at the usability of the system. So we were interested in usability, acceptability, and also whether we could predict engagement with the platform and predict the amount of data that people provided. So we measured usability using the post-survey system usability questionnaire. It has 19 questions that provide information about how easy the system is to use, how good the information is that is provided via the app, and sort of interface quality. And for acceptability, we use the technology acceptance model FastForm, which has 3 subdomains which relate to how useful they perceive the system to be, how easy it is to use, and predicted future use. On a descriptive level, the data were not terribly interesting. These questionnaires are really good for measuring sort of in-the-moment perceptions of usability and acceptability and providing indicators of what we need to tweak in the system in order to make it more usable and acceptable, etc. But they aren't validated to detect change in perceptions of usability over time. So descriptively, it was useful to make tweaks, but not very much to describe change over time. What we were more interested in was seeing if we could use this information to predict engagement with the system. And again, this is published if anyone is interested in reading the nitty-gritty. In this paper, we were effectively interested in looking at whether people with more severe symptoms perceived the system as being less usable and less acceptable. We were interested in whether lower perceptions of usability and acceptability resulted in getting less data. And then thirdly, we were interested in whether people who are more severely unwell provided us with less data, so higher levels of depression, anxiety, functional impairment, whether they were associated with receiving less data. So for our first hypothesis, we predicted that more people with more severe symptoms would perceive the system as being less usable and acceptable. We ran multivariate random effects regression models, and we controlled for age and years of education. Our predictor variables were anxiety severity, depression severity, and functional impairment. And our outcomes were total scores on the usability questionnaire, total scores on the acceptability questionnaire, and then 2 of the acceptability subdomains, ease of use and usefulness. So we found that people with a higher level of functional impairment, so people who reported that their depression severely impacted their ability to go about their daily life as usual, perceived the system as being significantly less usable. People with high levels of severity found the system to be less easy to use, or reported it to have lower levels of ease of use. And people with high levels of functional impairment overall reported the system to be less useful to them. For our second hypothesis, we were interested in whether perceptions of usability and acceptability resulted in receiving less data. And again, we ran multivariable random effects regression models. We controlled for physical comorbidities, employment status, previous wearable use, and traumatic life events that had happened in the last year. Our predictor variables were the usability and acceptability scores. Our outcome variables were the number of app-delivered questionnaires that were completed and the percentage of Fitbit wear time. And here we found that higher levels of perceived acceptability were associated with an increase in the number of questionnaires that were completed. Perceiving the system as being easier to use increased the numbers of app-delivered questionnaires that were being completed, and perceiving the system to be more useful was associated with an increased number of app questionnaires that were completed. Higher perceptions of ease of use were also associated with an increased Fitbit wear time. Our final hypothesis looked at whether more severe symptoms, so people with really severe levels of anxiety, depression, or functional impairment, provided less data. And again, multivariable random effects regression models, we controlled for age, comorbidities, education, employment status, wearable use, and life events. And we were interested in the associations between anxiety, depression, and functional impairment on the number of app-delivered questionnaires completed and the amount of Fitbit wear time. And here we found that higher levels of anxiety were associated with a reduced number of questionnaires completed, and a higher level of functional impairment was associated with a reduced Fitbit wear time. So from what I've described so far, it looks like there are some associations between depression, anxiety, and functional impairment severity and usability and the amount of data that people are providing. But when we actually look at the effect sizes here, what we're seeing are really, really, really small, clinically fairly meaningless effect sizes, which we think may have reached a level of statistical significance purely because of the size of data that we have available to us. So, and this is the case for all of these associations. So as an example, this functional impairment, what this means is that a 1 standard deviation difference in functional impairment is associated with a 3% reduction in overall Fitbit wear time across nearly a 3-year period. So really, really meaningless effect sizes that we think happen to have reached a significant threshold because we have a good sample size. So we take these findings with a pinch of salt, and actually our conclusions in the paper were that none of the things that we collected really meaningfully predicted engagement with the system with an effect size that we were confident was meaningful or useful. So yeah, we concluded that sort of large-scale digital data collection tools were usable based on the good levels of usability and acceptability reported, and also our findings that largely there was no particularly important effect sizes identified in our main predictive analysis. So finally, we were interested in acceptability, so how people felt about engaging with these sorts of technologies. And to do this, we conducted qualitative interviews with our participants throughout the course of follow-up. Again, this is published. If anyone's really interested, you're very welcome to go and read the paper. We collected qualitative interviews from around 40 participants at 3 months, 12 months, and then either at 24 months or whenever they left the study, when they finished their participation. We collected them from each country, and we tried to collect data from the same people each time, but that's not always possible. We conducted semi-structured interviews, which were either face-to-face or online, and the interviews asked for information about participation experience, how well they could integrate the technology into their daily lives, experience that they had with other apps or devices during the course of their participation, challenges they faced, how they used it to make decisions, and we conducted a deductive thematic analysis to try and collate these into some kind of framework. It was a huge amount of work done by one of my PhD students, and this is a really, very limited summary of her really fabulous work. But we effectively came up with a range of different aspects in which people thought this technology was good or bad or somewhere in between. There was a theme related to sort of the role of research, that people participate in research for altruistic reasons, knowing that they may not benefit themselves from it, but hoping to contribute to a wider societal change. And they also mentioned the importance of the support of the research team, which often in the UK goes above what they would have received if they were just receiving routine care via the NHS, for example. There was a theme related to clinical uses, so how they would want their data to be shared, ways in which they can see it being used in their current treatment program or as part of primary or secondary care services. We had a big theme relating to self-management and how people used the information that was collected during the study to increase their own awareness of their symptoms, to communicate about their illness to their friends, their family, their healthcare professionals, anyone that they wanted to explain it better to. And a lot of people talked about the overall value and benefit that the technology and the project as a whole brought to their experience of living with depression. There was a lot about the technology, so issues relating to how intrusive it could be, it needing to be convenient for integration into daily life, issues that people had with the technology malfunctioning, and then lots of information about how to make the system better. So from these interviews, we concluded that these sorts of data collection tools are acceptable, but we did come up with some caveats and some recommendations for how this could be improved if implemented into clinical care or integrated into other research protocols. So in terms of participant experience, it's absolutely critical that this work, this technology be introduced with a trusted clinician or a researcher. And a lot of people I speak to think that technology might inevitably replace the need for humans in healthcare and in mental health care, to which I say I think we found that is absolutely not the case. In fact, more human connection is required when using these kinds of technologies to make sense of the information, to support people and help people navigate through their symptoms. And this is even more important when we're talking about technology. There needs to be a clear explanation of the purpose of why the data are being collected. They need to know how the data are going to be used, how it will benefit either themselves as an individual or wider society in clinical practice. They want to know who will be able to access the data, where they're going to be able to access it, and what they would want to do with it, could they access it. There needs to be an accessible contact for as long as people are interacting with this technology to provide both practical support in terms of technical malfunctions, but also emotional support to help deal with some of the issues that arise when sort of being confronted with symptoms on a day-to-day basis. We had conversations about data sharing, so what should be shared and what shouldn't be shared. We collected geolocation data, which was a really controversial topic at the time, possibly not so anymore. But lots of people saying, I don't mind if you know that I go to Tesco, I just don't want you to know that I'm at Tesco at the moment. So that type of thing, like how we manage these more sensitive types of data were quite important. And it was really critical to people that they should be able to have real-time access to their own information. This wasn't something that we could provide in this study because we didn't have the resource to be able to create an entirely patient-friendly data interaction system, but they could access their Fitbit data, and at the end of the study each participant received their own personalised summary of everything that had been collected from them throughout the course of follow-up. Some people monitored their own step counts every single day. I had one participant who had an Excel spreadsheet where at the end of every day she put in her own step count, and she used that to train from basically being completely sedentary to being able to run a marathon by the end of the study follow-up. So people receiving and having control over their own data was very empowering to them, and people used it for really incredible things. In terms of the system and sort of technical setup, they wanted reminders about the passive data collection, so we thought that just having an app that quietly sat there was fine. They've recommended that there needs to be some kind of reminder that it's there, some kind of reminder that data are being collected and what it's being used for, which is now in existence in the app when you download it. They wanted motivational prompts for active data collection, so questionnaire prompts that don't just say this is due, but have some sort of motivation for why they should do it, particularly if they're tired, stressed, depressed. They wanted an opportunity to be able to report malfunctions in the app rather than having to call the research team. And they wanted to be able to opt in and out of data sharing, and also when they wanted their data shared. They also thought it was essential for anyone dealing with the data, particularly mental health professionals, to have adequate training in what to do when presented with this kind of information in a clinical environment. So our second aim is, what time is it? Sorry. Oh, perfect. Okay. So our second aim was to look at whether the data collected via these technologies was actually useful for sort of predicting outcomes or giving us indication of clinical state. And there are loads of papers which take each sensor and basically look at it and whether it's useful. So we've got one that looks at Bluetooth nearby device count via Bluetooth data. We've got phone measured mobility, so phone accelerometry data. We've got gait, so people's movement and steps and gait movements. We've got geolocation and homestay data. There's a lot of them out there. We've got a fairly recent paper which looks at the relationship between heart rate dynamics, and here you can see in one of their graphics an increase in heart rate in the 2 weeks prior to a depression relapse or a recorded relapse. And we've also got papers that look at sort of trajectories of cognitive function and their association with depression and function outcomes. So we've been able to look at some of these really, these associations longitudinally, which is really exciting. There are a load of papers published on the Radar CNS website. But what I'd like to finish with is a paper that we are working on at the moment. It's currently under review, which is one of the first papers to do a sort of a predictive analysis using the data to actually predict the onset of a relapse. And this is using wearable-derived sleep features, where we've been looking at the association between sleep duration, sleep quality, and sleep regularity and our depression outcomes. So depression was measured every 3 months via the Inventory for Depressive Symptoms self-report. And in order to, our two sort of outcomes of interest were relapse, which is meeting the World Health Organization criteria for a depressive episode. That's having at least one of the two core symptoms and at least 5 of the other symptoms. Scoring over 25 on the Inventory for Depressive Symptoms self-report, so showing a moderate level of severity of those symptoms. And it also needed to reflect a change from previous states, so they needed to have previously been in remission. And then we were also interested in just overall severity measured very straightforwardly on a continuous scale. And then our sleep predictors were sleep duration, so change in total sleep time. We were interested both in within-person variability, so the extent to which an individual changed from themselves. And then we were also interested in how an individual differed from the group average. And we were interested in that for change in sleep time and total sleep time. For sleep quality, we were interested in sleep onset latency, again, variation, within-person variation, and a change from the median, the group median. We were interested in sleep fragmentation index, so the extent to which people wake up regularly throughout the night, and sleep efficiency, so how much time spent in bed people were actually asleep for. And we were interested in regularity. So sleep midpoint is quite an important indicator of overall sort of sleep. If you sleep from midnight till 6 a.m., your sleep midpoint is 3 a.m. And according to the literature, the earlier your sleep midpoint is, the better that is. So we were interested in individual variation in sleep midpoint, group midpoint, change, as well as social jet lag. So social jet lag is when you sleep less during the week and then catch up for it at the weekend. And again, that's not thought to be a typically healthy sleeping behaviour, although we all work, so I don't know, that's just society. So we conducted either a logistic or a linear multivariate regression model depending on the outcome. Relapse was the logistic model and severity was the linear model. We included a participant level random intercept to account for the clustering of repeated outcome measurements within individuals. We adjusted for age, gender, education, partnership status, depression subtype, medication and alcohol use, and the hours of daylight in the previous month as a proxy measure for seasonal effects on sleep and depression. We included quadratic terms of the sleep feature to allow for non-linear associations between sleep and depression. And we also controlled for the participants' mean value of the sleep feature so that we could estimate within-person estimates. And for each of these outcomes, we've got the effect of each sleep feature summarized using an average marginal effect. So for relapse, this means that it's a percentage point change based in a 1 standard deviation difference in each sleep feature. And for severity, it is a change in total IDS score per 1 standard deviation difference in each sleep feature. So for sleep duration, we found 2 quite interesting findings: a change in individual variability in total sleep time, and an individual variability in total sleep time were both associated with around a 3% chance increase in the probability of relapse in the next 4 weeks, and a 1 unit increase in depression severity occurring over the next 4 weeks. So both of these represent an individual changing in their sleep pattern from themselves, not in comparison to the rest of the group. For sleep quality, we didn't find a huge amount that's relevant, except that a 1 standard deviation increase in sleep efficiency was associated with a decrease in depression severity. So for these models, the blue is unadjusted and the red is adjusted. The adjustment didn't make any difference, really. And for sleep regularity, we found that individual variability in sleep midpoint in the 4 weeks leading up to a depressive relapse could increase the predictive ability of relapse by 3%, and a change in sleep midpoint was associated with a 0.5 increase in depression severity. So to summarize these findings, we ran an additional analysis looking at population attributable fractions, which suggested that an intervention designed to increase consistency in adults with major depressive disorder could reduce their risk of relapse by 22% in the wider population. We found that intra-individual, so within-person variation in sleep was much more important than how someone compared to the overall group scores. And so our final conclusions were that consumer-grade sleep devices were able to identify some markers of sleep which were predictive of relapse in the 4 weeks prior to that relapse event happening. So to conclude, my overall talk, not just that bit, is that we have shown that it's possible to collect a wide range of data from participants with major depressive disorder for long periods of time. This study is now the largest digital data set in a clinical population in the world, and is continuing to be used to answer a whole load of interesting questions. We've published papers about procedure and methods, how to analyze the data, how to treat the data. New methodological methods are coming out of it, and we're also using this data to continue answering clinically relevant questions. The data can provide clinically meaningful information, but it's also really, really hard implementing digital technologies into any kind of protocol, whether it's routine clinical practice or a research design, is really tricky. It was difficult to even get ethical approval across the 3 different countries to be able to collect this kind of data. People underestimate the amount of ongoing technical support that's required. I had 3 research assistants working for me at the time, and they were fabulous and spent a lot of their time on the phone to people talking about Fitbit straps that had dropped off and how to restart phones and how to sync Fitbit devices. And their patience was extraordinary. It's also really tricky because you have to be technologically agile, and I think more agile than the scientific world we work in typically allows. So, for example, halfway through data collection, we had to switch our wearable device because they discontinued the Fitbit Charge 3. We had to start using the Fitbit Charge 4, trying to convince publishers, peer reviewers that our data are still meaningful even though there's a switch in device halfway through is tricky. And these kinds of quick switches that need to happen because of a change in infrastructure that is entirely beyond our control is really, really hard. But I think it's brilliant, and I think that it's a really exciting world that has huge potential to change the way in which we practice and the way in which we conduct our research. I worked with a load of different people on this project, and these ones were my favourites and the ones that we worked with the most. So I have a huge thanks to give to all of these collaborators across the different sites. And these are the slides that show our funders